Yes,
Professor Priya
yes,
Jagia from AIM, she had organized.
yeah,
Right. Yeah.
yes,
Last
yes,
year, I think the last a year ago or so.
yeah, yeah.
Yeah. That's great.
Ma'am, should we wait or can we start?
Yeah, I think we can start. I think Dr. Vimal is also here. He has also joined. Vimal, sir?
Hey guys, hi Tarun, how are you?
Hi, Vimal. Hi. Good to see you as well.
Good to see you after so many years.
Yeah, no, absolutely. Yeah. It's been quite a long time since you left UK, isn't it?
That's right, that's quite right, yes.
Yeah. That's
Thank you for being part of this. We really are looking forward to listening
no,
to
well,
you.
I must say it's my privilege to be able to, to have this meeting with all of you. And thanks to Bhavna to introduce me to this, your forum, your society. And thanks to all of you who have invited me to give me this opportunity to speak to you and share my thoughts on FFRCT. So let me know when you want me to start.
Yes, Tarun, I think we can start, but before that, I would definitely want to introduce Tarun for people who don't know. So,
Yes, Bhavna, go ahead, Bhavna, please.
yes, Dr. Tarun Mittal works as a consultant cardiothoracic radiologist at the Royal Brompton and Harefield Hospital in London. He's an honorary senior clinical lecturer at the very reputed Imperial College of London and an international professor of cardiac radiology. He has many accreditations and qualifications, including level 3 certification in both cardiac CT and cardiac MRI. And he is a member of all the known reputed cardiac imaging bodies. And he has multiple publications, and this is just a list of the recent ones. And obviously the first one is of interest, and that is related to the topic that we are discussing also, and it is going to be published in JACC. So that is great, Tarun. And then interestingly, he's a yoga teacher as well. And he's a teacher in mindfulness-based cognitive therapy. And his current research is on this very interesting mindful-based intervention in patients with pain in chest. So I'm sure we'll hear about it in future. But now today's discussion is CT-FFR. So me, Tarun and Priya ma'am, we were going back and forth because when ma'am asked me to do the February monthly meet, I knew when I knew Tarun because I'd attended his course in November, the UK Cardiac CT course. So those of you who don't know, it's a very reputed course, and we were 25 of us. I think it was 6 days, 10 hours, Tarun, if I'm not wrong.
Intensive 6 days from 8 a.m. to 6 p.m.
Yeah, 10 a.m. to 6 p.m. I think the longest I've ever survived, closest is probably Sanjay sir's class, but the jokes apart, it was a fantastic course. We learned so much. And it was interesting that he would give small talks in between these cases that he would show. And one of the talk that I really liked was the CT-FFR because we do use it quite extensively. And this talk gave a different perspective to it. I don't want to say anything more because I leave it to Tarun. So I kind of convinced Priya ma'am because I knew most of us are not using CT-FFR, but some of us might be thinking of using it. So I thought it is good to hear a different perspective. Tarun has worked extensively on CT-FFR. So today's session is very important also because it is part of the SCCT guidelines. So I thought we should definitely, understand what it actually means both clinically and financially. So I am not going to present anything today. So this entire 1 hour is for Tarun. So Tarun, floor is yours.
Okay, well, thank you very much, Bhavna, for your kind introduction. And just to say, you can see with my interest in yoga and mindfulness meditation, I'm very much an Indian at heart. So although I may live and practice radiology in UK, but I'm very much Indian, and I have a sense of belonging to all of you who are trying to develop cardiac imaging in India. So thank you very much. Let me share my presentation. Screen 2. Okay, so the title I have given to this presentation is FFRCT.
Share your, we can't yet see your screen, Tarun.
You can't see my screen? Okay, that's interesting. It again. Can you see it now?
Yes.
Okay, excellent. So the title of this talk is FFRCT, its background, evidence, and results of a multi-center audit that Bhavna mentioned that is being published now in JACC Cardiovascular Imaging. So may I ask you a question, those of you who are working in India, is anyone using FFRCT at all in your practice?
Tarun, Vimal here. We tried very couple of cases, but just it never worked out for us in terms of pricing and the turnaround time that they were offering to us. So in all practical basis, we haven't. We've seen a couple of cases as a trial, which we send, but otherwise, no.
Okay, yeah. Anyone else? So I gather that probably no one is using FFRCT in India, and largely the reason could be cost of the procedure, which could be prohibiting based compared to the cost of other stress emitting techniques and also invasive angiogram in India, itself being cheaper perhaps compared to FFRCT. So just to give a background idea of the extensive range of indications that we're using cardiac CT for in practice, and this is in my own hospital, where you can see the whole range of reasons why cardiac CT is being performed, right from asymptomatic patients to for risk assessment to patients with stable chest pain, acute chest pain, with stent assessment, bypass, post-bypass assessment, heart transplantations, etc. The large proportion of patients nowadays, we are doing cardiac CTs for patients who are being assessed for TAVI procedure. But by far, the largest proportion of indication for cardiac CT is stable chest pain, which is which probably would be true for India as well. So let's just get a brief background of chest pain itself. So we can categorize chest pain broadly into two types. The first one being acute chest pain, where we see there is rupture of the vulnerable plaque, resulting in formation of thrombus in the lumen of the coronary artery, causing partial or complete occlusion of the coronary lumen, resulting in myocardial infarction. And we categorize acute chest pain as STEMI and STEMI or unstable angina based on the degree of coronary artery obstruction, luminal obstruction. And the other category of chest pain is the stable chest pain, which again, based on the type of symptoms and how the symptoms are resolved, is divided into typical, atypical, or non-anginal chest pain. And while the acute chest pain is resulting from acute rupture of the vulnerable plaque, the stable chest pain develops because of the gradual, long-standing formation of plaque in the intima of the coronary arteries, resulting in narrowing of the lumen of the coronary artery. You can see here in this diagram, which causes reduction of the blood flow to the myocardium on stress, on exercise, so that the amount of the oxygen supply to the myocardium is not met on stress, but becomes normalized on the resting phase. And this is the concept of ischemia. So we can identify the degree of coronary stenosis in a patient presenting with stable chest pain, either anatomically by demonstrating the degree of luminal narrowing, or by demonstrating if there is any ischemia on exertion. And hence we have two broad types of investigations, imaging investigations, that are being used to determine or exclude presence of obstructive coronary artery disease. So one kind is anatomical tests, of which we can say divide them into non-invasive tests for coronary artery stenosis, which include CT coronary calcium scoring and CT cardiac angiogram, or invasively by catheter angiography. And then we have the different functional or stress imaging tests, which can be performed with exercise or can be performed with different kinds of pharmacological agents like dobutamine or adenosine, combined with a variety of different imaging techniques. And then we have the invasive functional test, which is called fractional flow reserve, or also called invasive fractional flow reserve, instantaneous fractional flow reserve, which is performed in the cath lab. And now, more recently, which is the topic of today, we have the non-invasive fractional flow reserve, which is derived from the anatomical CT angiography images. So these are the different types of investigations we perform in patients presenting with stable chest pain. Now, in UK, we have a body called NICE, standing for National Institute for Healthcare Excellence, which provide us guidance for diagnosis and management of different clinical conditions. So in late 2016, it came up with its guidance regarding assessment of patients presenting with stable chest pain. So what this guidance said, that in patients who have known CAD, meaning that they've had previous bypass surgery or PCI, the first line of investigation should be stress imaging with any of the imaging techniques that are available in a particular hospital. While in patients who are not known to have previous coronary artery disease, so these would be the bulk of the patients presenting with stable chest pain. If they have typical chest pain or atypical, or if they have non-anginal chest pain, but with ECG changes, then for these patients, they recommended the use of CT cardiac angiography with 64 slice or more scanner as the first line of investigation. And when this is done, and it shows that there is severe stenosis in one or more coronary arteries, then patient can undergo a catheter angiogram after that. But if the CTCA shows patient has moderate stenosis or uncertain stenosis, then this could be further investigated with stress imaging technique. And if that shows that there is severe ischemia, then patient could undergo a catheter angiogram. While patients who on CT shows mild stenosis or no stenosis at all, no plaque formation, then they do not require any further imaging, and their chest pain could be labeled as non-cardiac chest pain. So this is a guidance that the NICE came up with in 2016. And I must say that these were quite bold guidelines, because it was only in 2019 that the European guidelines that try to emulate this in some form. And now, more recently, the 2021 ACC guidelines have also tried to emulate this particular pathway in their guidance. So now just a bit about the FFR. So FFR stands for fractional flow reserve, and traditionally is performed invasively in the cath lab. And it is performed in patients where on the initial coronary angiogram, the stenosis is thought to be moderate in degree, where the cardiologist is not sure whether the stenosis is severe or not. So what they do is that they introduce a pressure wire in the coronary artery across the stenosis. They induce maximal hyperemia by injecting intracoronary or intravenous adenosine. They measure the pressure just distal to the stenosis, and they measure the pressure in the aortic root here. So the ratio of the pressure between the distal to the stenosis to proximal to the stenosis is called the fractional flow reserve. And normally in patient with normal blood flow or no stenosis, this ratio is 1, close to 1. So if this ratio is less than 0.8, then the degree of stenosis functionally is considered to be abnormal or functionally significant stenosis. And this technique is considered to be the gold standard technique for assessment of ischemia. Now, there is another version of this technique, which is called instantaneous wave-free FFR. Now, in that technique, there is no administration of adenosine, and it uses certain different principles of calculation of the FFR. And in that technique, in instantaneous wave-free FFR, the cutoff value is 0.89 compared to the standard 0.80 for standard adenosine FFR. So just important to keep this in background, because it is the technique of FFR-CT, which we are going to discuss next, is based largely, the concept is based on the invasive FFR technique. So now we come to the FFR-CT, which has been commercialized largely by one company called HeartFlow. And as you might know, HeartFlow as a company is based in California, and other companies and other institutions have also tried to bring about their form of FFR-CT, but HeartFlow was probably the first one to bring out the different trials comparing FFR-CT with invasive FFR-CT. It's called invasive FFR, and they were the first ones to patent the technique, so no other company has been able to commercialize this particular technique as how HeartFlow has been able to do so. So after a few months of NICE bringing out its guidance for the use of how the patient with stable chest pain should be investigated, it then brought out in February 2017 the guidance of using HeartFlow FFR-CT from coronary CT angiography. And what this guidance said, that the use of HeartFlow FFR-CT is supported by evidence, and I will show you this evidence, what the evidence was. It said the technology is non-invasive, safe, and has a high level of diagnostic accuracy. So this was again based on that evidence they used. Then it suggested that the HeartFlow FFR-CT should be considered as an option for patients who present with stable chest pain as part after CCTA, as part of the NICE pathway on chest pain. So the pathway I showed you on a previous slide. And they said that this would lead to a cost saving of so much 214 pounds per patient if FFR-CT is used. And overall to the NHS in England, it could save so many million pounds by 2022. So those are the claims based on their own cost-effective analysis performed by them. So in this pathway that NICE guidance has suggested, FFR-CT would fit in somewhere here as an alternative to other stress imaging techniques. So where patients have moderate stenosis, then FFR-CT could be used. So how is FFR-CT performed? And I'm going to explain to you very briefly this technique of HeartFlow FFR-CT. So the CTCA is performed locally using a 64-slice CT scanner or more, using best quality measures, including administration of beta blockers, etc., to get the best possible image quality. Then, if the radiologist finds that the degree of stenosis is moderate or is uncertain and image quality is good, then they can choose to transfer the images from their PACS to the HeartFlow server. And the way their platform is that the images are automatically anonymized as they are transferred to the HeartFlow server in California. So when the images arrive on the servers of the HeartFlow, then their software, the first thing it does is it reconstructs a 3D volume rendered image of the coronary arteries from the CTCA images. That's the first step that occurs. And then in the next step, they use what they call supercomputers, using technique called computational fluid dynamics. The supercomputers, they calculate certain blood flow equations, also called Navier-Stokes equations, which basically calculate the degree of pressure in the coronary arteries based on certain physiological assumptions. And there are three assumptions that their model assumes. The first is that the coronary arteries would have a certain demand of blood flow and oxygen if the blood flow is increased on stress. Second is that the boundary conditions of the coronary arteries, the boundary conditions at the aortic root and the myocardium itself, they are correct and accurate. And third is the effect of adenosine on microcirculation in the myocardium. So these three physiological assumptions are made in calculating the pressure in the coronary arteries. And then the result is that they provide a 3D interactive map of the coronary arteries, where the user can put a point. You can put a mouse in the coronary artery, and it will give you the pressure, which is the FFRCT at that particular point. And I will show you some images to illustrate that. Now, so the first study that they published was back in 2011, in which they recruited 103 patients who were undergoing invasive FFR. These are patients with a stable chest pain. So they found a reasonably good accuracy. You can see here good sensitivity, specificity, positive and negative predictive value of FFRCT overall in these patients. But when in the study, they mentioned that when they looked at patients who had moderate stenosis on CTCA, then the accuracy and the positive predictive value of FFRCT was no different compared to just CTCA itself. Then the next slightly larger study was called the de facto study, and this was published in 2013. And here they had more patients, but the degree of accuracy was found to be much lower than their previous study. So you can see the specificity was lower. The positive predictive value was 41% compared to 74%. And they ascribed this reduced accuracy largely to the software version they have used. And they thought maybe it is not, there are some limitations with the software at this stage, and hence the accuracy was reduced in this particular study. Then they came up with a third study called Next trial. And this enrolled a much larger proportion of patients. And this study showed that the sensitivity, specificity, positive, negative predictive values of heart flow FFRCT had much improved at this time by the improved version of the software. So you can see the positive predictive value went up from 41% to 74%. And in this, they're comparing the diagnostic accuracy of the FFRCT with the invasive FFR. Now, a meta-analysis was published in 2017, in which it included all the heart flow studies and also a study from using Siemens FFRCT. And what this meta-analysis found was that FFRCT is quite accurate when its value is lower than 0.6 in particular, or it is accurate when the FFRCT value is higher than 0.88384. But its accuracy in the mid zone is not as good. So it came out to be about 0.5 or something. Now in UK, if you remember, the FFRCT guidance was brought about by NICE in February 2017, but it was not until April 2018 that the hospital trust started to use this technique. And this was because the heart flow applied for funding to the NHS England to a program called Innovation and Transformation Project. So the funding was provided to the hospitals who could use this technique centrally. So the hospitals don't really have to worry about their own funds to use this technique. So this technique was funded by the NHS England for a period of 3 years. And by December 2020, about 62 NHS trusts in England had got themselves enrolled to use this HeartFlow FFRCT, and around 16,000 CTCAs have been sent to HeartFlow for FFRCT analysis. In my own hospital, between Harefield Hospital and Royal Brompton Hospital, we set up the technique in October 2018. Since then, we used it till end of the March 2021. So we used to send patients so that the decision which patient CTC images go to HeartFlow or not was dependent upon us as cardiac radiologists who were doing the reporting the technique, the procedure. So the criteria that we set for including patients for FFRCT were that they should be having stable chest pain, which is according to the NICE guidelines. Their image quality should be diagnostic for the whole coronary arterial tree in at least one phase of cardiac cycle, and the degree of stenosis should be between 50 to 90%. We were sending some patients if their degree of stenosis was less, but they had higher risk plaque features. But I must say, majority of the patients we sent had a moderate degree of stenosis. Then, if patients had other symptoms or were asymptomatic or have had previous CABG or PCI or had acute chest pain, or if the plaque was obliterating the lumen completely, because you need to have some lumen for the boundary condition to be detected, or if the image quality was not optimal in any of the phases, then we would not send the CTCA for HeartFlow FFRCT analysis. So these were the inclusion and exclusion criteria that we set up in our own hospital. I'll show you some examples. So first is 71-year-old women who had presented to the local chest pain clinic with pain in chest lasting 20 minutes on walking uphill. So typical chest pain. She had no risk factor for cardiovascular disease. And this is the CTCA, which shows that she has an eccentric non-calcific plaque here. You can see there's some small calcific plaque, but this non-calcific plaque was labeled as causing moderate degree of stenosis in the cross section, as you can see here. So my colleague sent this scan of the CTCA images to HeartFlow FFRCT, and you can see here the FFRCT value is 0.88. So it's greater than 0.80. So this is not functionally significant, according to HeartFlow. Now, this was sent the patient for some reason, maybe a patient was having, typical symptoms. So patient underwent an invasive cardiac angiogram, and you can see the stenosis was indeed very mild here. So nothing further was done to this patient. Now, second patient is a 53-year-old man who had been having typical chest pain for a year or so. And this patient was referred to us for CTCA. And again, patient has an eccentric non-calcific plaque. This is a lumen here. So we labeled this as moderate stenosis and sent this CTCA for FFRCT analysis. So here, the FFRCT came out to be positive, less than 0.80, suggestive of ischemia in the LAD. So this patient underwent an invasive angiogram. You can see here the narrowing. And the cardiologist did an invasive FFR. And here you can see the value 0.94, which is not significant at all. So what this shows is that the FFRCT here in this case was false positive. And when I went back to the CTCA and did some quantification using the software tools, which I'm sure most of you are familiar with, and quantify the degree of stenosis. When you compare it with the reference level, the degree of stenosis was around 40%. So you could see that when we quantify, our eyes could be perhaps overestimating the stenosis, but when you quantify it using the tools available, then the degree of stenosis was actually not in the moderate degree, it was less than moderate, in the mild degree. So, and hence it was not significant. So third patient, 60-year-old man presenting with central chest tightness occurring without exertion. So a non-anginal chest pain, but the patient also had breathlessness. So referred for CTCA, and you can see here, there is a focal, largely non-calcific plaque in the proximal RCA. And we call this stenosis as severe, causing more than 70% luminal narrowing. So ideally, this case should not have been sent for FFRCT, but it was sent because we were just, I think, testing out or trying out FFRCT procedure. So to our surprise, the FFRCT here in this patient was normal. You can see value is much above 0.80. But because we ourselves thought that, look, this looks like severe stenosis, there's no way that this can be severe stenosis, this can be mild stenosis. So the patient underwent invasive angiogram. You can see tight stenosis anatomically here. And the invasive FFR was also positive at 0.77. So this is a case where FFRCT was false negative. So another case of 76-year-old woman who has been having some episodes of rest chest pain. So she underwent CTCA, which showed multiple calcific and non-calcific plaques in the coronary arteries. And in this particular level, we thought the degree of stenosis is at least moderate. So you can see the lumen is here. This is soft plaque, this is calcific plaque. So perhaps it would have been severe as well. So CT scan was sent for FFRCT, and this showed that the degree of stenosis is mild, 0.84 FFRCT value, so not significant functionally. So we went back to HeartFlow representatives. We told them, look, we are not very happy with this result. We think the degree of stenosis is severe. So they they asked the HeartFlow team in California to reanalyze this particular study. And they came back to us saying that this was the statement from their own document. It was determined that the segmentation was slightly oversized into non-calcified plaque in this area. So what they did was they changed the boundary from original boundary, as you can see here, to a boundary that is narrower. So when they reduced the boundary with the minimal luminal diameter from 1.3 to 1.5, now the FFRCT value came as 0.78. And you can see how they changed the boundary from the initial analysis to subsequent edited analysis. And hence, they could obtain a FFRCT value of what we thought as cardiac radiologists to be more correct. And hence, the point I would like to make with this is the boundary condition is very, very important for accurate FFRCT value, right? If we are not able to judge the boundary correctly, then even the computer will not be able to judge it correctly. Now, so this was the result from 0.83 to 0.78. Now, this patient hence underwent an invasive angiogram, and this is how it looked on invasive angiogram. So this stenosis doesn't look severe. Cardiologists thought it's mild. They didn't do any FFR, so we don't know truly the functional significance of this lesion. But you can see how fallible the technique is based on how well the boundary is defined on the CTCA images. So now in the interim, now going to 2021, there is a body in a government body in England that came up with this guidance called GIRFT, Getting It Right First Time. And as part of this, the British Society of Cardiology, it made some 25 recommendations to improve cardiology services in different ways. And one of these 25 recommendations was that CTCA should be available to all hospitals throughout England, including CT-FFR. Yeah, so this became a big thing, and like all the radiology departments throughout England were being kind of pressurized to use CT-FFR for patients with moderate stenosis. So at this point of time, some of us so I am part of a group of cardiologists called British Association of Cardiologists of Indian Origin. So a number of us have been doing CTCA and have been using CT-FFR. So we thought, maybe it's a good time to pull together our experience of how good CT-FFR is in our practice. So this led to us doing this multi-center audit. So 12 NHS trusts throughout England were involved in this particular audit. And each center, they submitted the data of the CTCAs that they had submitted to HeartFlow for FFRCT over the 3-year period when the technique was funded by the ITP program. So the objectives of this audit was we wanted to know how many patients or what proportion of patients who were referred for FFRCT actually had stable chest pain, which was the guidance by the NICE. How many patients had CTCA stenosis of uncertain functional significance, or in other words, a moderate degree of stenosis. We wanted to assess the diagnostic accuracy of FFRCT in real-world practice compared to what the different trials have shown. We wanted to know the prognostic value of FFRCT for non-fatal MI on all-cause mortality. And we wanted to assess the how costly the strategy of using FFRCT would be compared to the strategy when we use different other stress imaging techniques in clinical practice. So what we did was we asked each center to submit their patient demographic data, presenting symptoms and risk factors. They submitted the results of CTCA and FFRCT as clinically reported, so not changing the report in any way or the interpretation in any way. The results of any downstream testing, including stress imaging, catheter angiography, invasive FFR, were performed. The outcomes of their patient in terms of non-fatal MI and all-cause mortality. And then we performed a cost analysis of FFRCT strategy versus other stress imaging strategy with the help of the Center for Health Economics at University of York, one of the most renowned center of health economics in the world. So what we found with this audit. So just to say, out of roughly 2,300 patients whose data we obtained, around 100 patients, which was about 7% patients, the HeartFlow rejected the scans because of poor image quality. So there was a 7% rejection rate in this audit. So that compares with other studies also. So the different studies, they report a rejection rate of anywhere between 5% to up to 20% or so. So in our audit, it was 7%. Now, if you look at the results in terms of symptoms, what we find is that about that CTCA was sent for FFRCT in stable chest pain symptoms in about 3/4 of them. So the rest of the patients had, acute symptoms. You get 6% patients acute symptoms, You can say 5% has only breathlessness. And then you can see 1% patients here, 3% here, and 2% here. So roughly 6% patients were totally asymptomatic. They had no symptoms whatsoever. And still the images were sent for FFRCT analysis. Now, in terms of degree of stenosis on CTCA, we found that only 40% patients had moderate stenosis on CTCA. And it was quite interesting to know that that even some patients even had normal CTCAs and were sent for FFRCT, or like 2% patients had complete occlusion of one or more coronary artery and were sent for FFRCT. Then in terms of diagnostic accuracy, so it is, if you focus on the results here in orange bars, the blue bars are the accuracy results from the next trial. So what was quite interesting was to see that the specificity and the positive predictive value of FFRCT in this real world data was quite, suboptimal compared to the next trial results. So this was quite revealing, and this kind of, matched with the experience I was having of using this technique at Harefield Hospital. So, this is a very low positive predictive value for any technique. Then in terms of outcome for non-fatal MI and all-cause mortality, we did not find any difference whatsoever. You can see the FFRCT value of 0.80 was not predictive of outcomes. Then this is our cost analysis model here. I can explain to you if someone wants to understand how we did this, but you can see this is our test strategy of FFRCT, and this is where we compared with other stress imaging techniques like stress echo, stress CMR, PET, stress and nuclear stress techniques, etc. And what our analysis showed that the FFRCT, so this is the value of FFRCT here, the cost of using FFRCT strategy is, you can see, almost 4,000 pounds per patient compared to, you can say 1,300 for dobutamine stress echo, or more expensive techniques like stress MRI, 2,300, 2,900 pounds. So overall, we found that FFRCT strategy was costliest. And the reason for that, you can see, is apparent from here, that because of low positive predictive value of FFRCT, the number of patients who would undergo diagnostic angiograms, invasive angiograms, and PCIs would be much, much more compared to other techniques. So in real world practice, HeartFlow FFRCT, these are the results of the audit, that patients were not being referred as per the NICE guidelines. FFRCT had low prognostic accuracy, low diagnostic accuracy. It is not predictive of clinical outcome and is costlier compared to the stress imaging techniques that are used in clinical practice. Now, what I think is that the reason for low diagnostic accuracy of FFRCT is largely due to the limited spatial resolution of CTCA for accurate quantification of FFRCT by the TIC technique of computational fluid dynamics. And this is because of limited spatial resolution. The boundary between the plaque and the contrast interface is often inaccurate, leading to inaccurate results of FFRCT. And again, what we don't know is, what does FFRCT people do, the HeartFlow people do, in patients who have purely calcified plaques? So how do they account for the boundary of the true boundary of the plaque? Because we know that there's blooming from pure calcific plaques. So where does the software demarcate the boundary of the true plaque and the contrast in the lumen? So we presented this audit in the British Cardiology Conference last year in June. And so you can see this work involved a number of colleagues from different centers. And I'm very thankful to all the colleagues for participating in this audit. And thank you to all of you for hearing me out on our experience of using FFRCT. Happy to take any questions from you.
Thank you, Tarun. I think, as I said last time, I think I was very surprised because we use it so often and I really don't know now. I mean, it was difficult after I heard the talk what to do because most of the cases where we say mild or moderate get referred to CTFFR. They kind of base the treatment on it. So before I ask my questions, I think I'll let the audience say what they want to say or ask you if they have anything to ask about CTFFR.
Hi, I'm Dr. Pudiyan here. I just have one question. So in the UK audit, you said that the positive predictive value for CTFFR is pretty low. Whether a sub-analysis of the data was done on which type of CT scanner these images were acquired, whether it was a 64 slice, 128 slice, dual source, and whether there was any difference in the output or the performance of heart flow depending on the scanner the images were acquired?
Yeah, we didn't do any sub-analysis. So all the scanners for 64 slice or greater, which is the requirement by the heart flow itself. So they do state that the image quality should be that is obtained should be best possible, with use of proper adequate beta blockers, etc. Heart rate should be less than 65. So they have strict criteria. And before they allow any site, any hospital site to take part in their program, they actually visit the site, they assess the quality of scans being done. So only if they're happy would they accept a particular hospital for their service. Okay. So because it's very much standardized, so I would say that probably there would not be much difference in the image quality between different scanners.
Okay.
One question, Dr. Tarun. So in case of on CT angio, the plaque is not flow limiting, but it shows high risk features. So how do you guide the patient for the treatment then in your setup? Okay,
so there are guidelines by the SCCT now what to do in such cases. So if the plaque that we see on CTCA has high risk features, for example, but it is causing less than 50% stenosis. So we can say in our report that the plaque is causing less than 50% stenosis. So you don't need to do any further testing for ischemia or stenosis further. But you can say that because of high risk features, patient could be put on aggressive preventive therapy. And what I think would be a good idea, instead of us radiologists suggesting what the preventive therapy should be, is to copy and paste the table from the SCCT guidance in your report at the end. And most patients are referred by cardiologists, they understand what preventive therapy is, and they can look at the guidance, and so be it. You want to only say to the extent that your referring cardiologist is happy. They don't like us to become cardiologists, in my view. They feel very defensive about their practice. But it's also important at the same time that we highlight the high risk nature of the plaque or the high plaque burden, which indicates the risk of subsequent events, and not just say, okay, there is no significant stenosis despite the plaques and not do anything. That's probably the biggest mistake we can make. So it's a good question, and I think everyone is asking about what we should do in this situation.
If there are no other questions, I've got multiple questions for you, Tarun. Sorry.
Okay, Vimal, please.
I may have missed this, but when we looked at the specificity and sensitivity, what was the gold standard? Because I'm sure a lot of them did not undergo an invasive FFR in your audit. What did you take as the gold standard in these cases?
So so the sensitivity and specificity, so all those diagnostic parameters, they were only calculated only for patients who underwent invasive FFR,
Okay.
not for everybody. So there were 213 or 214 patients who underwent both FFRCT as well as invasive FFR.
So that's about 10% of the entire data
Yes,
set that you have seen.
that's right, about 10% or so.
In that. And after the period went away of the trial, is NHS Trust self-funding FFRCT right now through HeartFlow?
Yeah, so they have now gone to a different way of funding them. So funding is still available. You know, everything is funded through the government, as you know, NHS, through the central government. So instead of ITB funding, which was a temporary funding, now they've got to another form of funding called MedTech funding.
Okay.
So that is available. So like in my trust, we, as you know, Vimal, we are a tertiary heart and lung hospital between Brompton and us. The facility to facility to perform or to obtain FFRCT through HeartFlow is still available, but none of us who were involved in this audit and who were obtaining the FFRCT are really keen on this as such. So what we are said to our cardiologists is that, look, it's available if you want it. If you want it for a particular patient, you let us know. And if after CTCA, we will send the images for that patient to HeartFlow. But we are not sending all CTCAs with moderate stenosis to HeartFlow now. And to my knowledge, in the last 2 years, we haven't sent a single patient for HeartFlow capacity.
So this might be a slightly tricky question, but do you think these results are because the HeartFlow technology is bad? Or do you think the whole concept itself is inaccurate and we will never be able to predict? Apart from the fact that, you know, the resolution of images are not great, etc.
Yeah. So, Vimal, this is my personal belief. I think the principles of the HeartFlow, the principles of CFD are probably good because they have been used in the industry, in the engineering industry since last 3 or 4 decades. So designing any of the automobiles, for example, that we use, particularly high speed, using planes, aeroplanes, etc. So all of them use CFD techniques. So I think the technique is accurate itself, but I think the limitation is because of the not so good spatial resolution of CTCA. Still, although we say it's 0.330 or 0.35 millimeters square. I think it needs to be further better than that for FFRCT to work in practice.
Vimal, can I butt in?
Please go ahead.
So Dr. Tarun, if I got it right, you are saying that you don't use this tool, and Bhavna, you are saying you use it all the time. So what's happening?
Bhavna?
Yeah, ma'am. So we really use it quite a lot. So how it works in our hospital is we are 2 of us are reporting. So only one of us have the control to send it. So it's like my colleague, whenever he sees something as mild or moderate, that gets sent, and then we get a report, I think after 3 to 24 hours, and then we put it back into we just add an addendum or a report. We just put the results into the system. And I think based on that result, the cardiologist decide what to do with the patient. So I was very happy thinking that it was really helpful until I heard Tarun's talk. So now, I mean, even now I don't send, but obviously like we do get cardiologists asking for it quite often. And then we do send it and we put it in the report. So there is nothing much I'm doing apart from just doing what the practice is. Because what do we argue upon? I think when Tarun finally gets published in JACC, maybe there'll be some grounds to say. And I was actually very surprised because there is so much cost constraints in NHS going on currently, and we are really spending so much money into CTFFR. And it is sad that, it is not as good as at least I thought.
Yeah.
So, Dr. Tarun, what would you say is the standard of care in UK? I think both of you are using NHS and
No,
one
absolutely.
person.
Yeah, absolutely. And I think it's personal experience. Each one is entitled to their way of investigating patients. But I would say that reflecting on the practice UK-wide, I would say that we can be very good. We can be reasonably good, with our experience on how we interpret the degree of stenosis. Using correct method, correct technique, our positive predictive value just on CTCA can be highly accurate, I would say. And we know a lot of people say that having calcific plaques are a disadvantage with CTCA. I would say, and I think Bhavna would second me once she has gone through the course, that there are techniques, there are methods by which we can actually use calcium to advantage on CTCA. So if we know the correct way of interpretation of coronary artery stenosis, I think our positive predictive value will be much better. And we don't need FFRCT as it stands now. And where we are not sure, we definitely use our existing stress imaging techniques, which I think are far superior compared to FFRCT. And I think cost-wise, FFRCT does not hold any grounds at all. It's costing us now in NHS, the cost is around £700 compared to the cost, which is 70,000 rupees in India, and compared to cost of CTCA, which is average £250 in NHS. So you are paying to a company just to analyze the images that you have done all the hard work already. They're charging 3 times that amount to process your images and giving you a value. And I'm sure in India, you can obtain a stress echo, for example, in the same price as you will a CTCA. And the cardiologist will be happier with the results of the stress echo done by a good cardiologist. So I think the cost-wise, it's very expensive. Accuracy-wise, it's in my experience, it's completely useless. So it's a good technique to understand, good technique to know, and it's good that in England we have had the opportunity to use it to assess it. But as a CT person, I was very excited when the technique came out, and we thought, my goodness, this will make a CT as a one-stop shop, provide both anatomical and functional assessment. But I was very disappointed.
Thank you. These are wonderful words to hear from you, because I don't think in my institution, CMC Vellore, we can ever afford heart flow for patients.
Right, yeah, absolutely. I think cost is so important in healthcare, and we should all be very, wary about the costs that we're incurring.
I've got an anecdotal story about the cost, which I'll reserve till the end, till others ask.
Okay, well, okay.
It's something very funny which happened to us. Anyone else who wants any questions, please go ahead.
I think I just have maybe 2 questions, Tarun. If
sure.
the CT-FFR was in a situation like the heart flow was something that we had, like we have a Circle software any software we have for cardiac MRI. Do you think us using it and seeing how it is being segmented?
Yeah, that's a good question. And I'm waiting for a software like this to come, like I used Terraricon software in my hospital. So if Terraricon can bring about a software, a module of FFRCT, which I can use and try it out, which is not costing anything more, maybe initial purchase of that module, then I can, I can assess it in my own practice. But here, cost is an important consideration, a very important consideration.
So my next question is, assuming that, I mean, if there was a chance that FFR was probably freely available, would there be any situation you would use it, given the
So
current?
then I would say I would be more open to try it out. It doesn't mean that will be accurate. That doesn't mean it will be accurate because of the limitations of spatial resolution. But at least we can try it more widely in our own hands, in our own institutions. So, but as you might know, Bhavna, that the HeartFlow has acquired all the possible patents in using FFRCT, and have basically squashed every other company from bringing out any software. Like Toshiba, which is called Canon, they brought out the FFRCT software as part of the Vitria software, but they are not able to promote it anymore. Siemens brought out their software. Again, they can't promote it anymore. So every other company has been, washed out of business.
I think Vimal said, yeah.
Okay, so about pre-COVID, one of the main chief engineers of HeartFlow who was involved in this happens to be our chairman's son's roommate in US.
Okay.
So they both were together. So Dr. Devi Shetty's son and him were together, and Dr. Devi Shetty's son is now the director for us. So they approached him and they came to us and said, we would like to bring HeartFlow to India. So they came to India and they said, I met them and I said, great, we would be very happy. What's the cost? They said, we do it around $1,500 in US. We will do it for 1,000 in India. Okay. And we all looked at it and said, $1,000, we probably will get a bypass at that cost in our hospital.
Absolutely.
Why would you want to do all this? So, but they were very keen on meeting Dr. Devi Shetty. Okay, so we went together and met. This was a big entourage. And I kept telling them, see, we charge, at that time, we were charging somewhere around 1,500, not 1,500. We were charging around 11,000 rupees for a CT scan.
Okay.
If I charge 11,000 rupees for a CT scan and you're asking 80,000, 90,000 rupees for FFR, nobody will do. The maximum anybody will do is $300, maximum. It was my estimation. I said $300
I agree.
Is something doable. So we go to Dr. Shetty. So Dr. Shetty says, great, this sounds very good. How do you guys do this? And the first thing they said, we need a 24-hour turnaround time, which in India doesn't work. Our CT reports go out in 4 hours, so we can't keep waiting for that. So Dr. Shetty said, why don't you shift your lab to us? We will do the processing for you. It'll bring down your costs. Okay. Right. And that was a model he gave. And Matt kept on going. And then he said, why do you want to do it for just people who have disease? You do it for everyone. Charge them 700 and it'll be okay. And these all guys became very happy. They said, okay, we can do it. It's a little tricky. We can do it. And they all came happy outside and said, Dr. Vimal, you said $300. Dr. Shetty agreed for $700. I said, he said 700 rupees. So even on, and those guys never came back to us. Those guys never came back to us because Dr. Shetty said the only way you can make it work in India is if you give it for cheap. If you give it for 700 rupees, we'll do it for everyone. We have no problem. We'll charge uniformly. We'll do it for everybody. You will make your money. And his point was very valid, which is where I think, Tarun, we all echo the fact that they have been very, very restrictive in anybody coming up with any models. Their IP rights have been very tight. And Dr. Shetty told them one thing. He said, the cost to build the software, you have already put that cost. There is no extra cost that you're putting to build your software. From now, whatever you're doing is only making money. So you should not be charging this much, and rather you should be ramping up in terms of your delivery, etc. So HeartFlow have got, practically they've got blood in their hands of CT coronary angiography for a lot of people. I think in India, Bhavin uses it. Bhavin has access to it. Bhavin has used it for a few cases, but I don't think any of us can afford it as of now.
No, that's true. And you rightly say, I mean, Dr. Shetty is what I have heard about him is very cost conscious, isn't it? He's driving down cost of everything in his hospitals.
Yeah,
And he will certainly, I totally agree with you that he would not be happy to pay to a company outside so much amount.
absolutely.
There's no way at all. No way. You can, as you said, that you can have a bypass done in 1 lakh rupees in
Absolutely.
Yeah.
Tarun, one last thing. Could we take this opportunity to invite you to come for our annual conference in Coimbatore in the month of October, if you're free, please?
I will be delighted to. I would be delighted to come and take part in the conference. Certainly, will be. I might be in India already in that time. At that time, so yeah, but certainly I would love to take part.
We will reach out to you with the finer details, so
Okay.
you know the dates and stuff. So that would be fantastic.
And let me know in any way if I can be involved with the IACI. Very much will be happy to contribute to and to learn from all of you, because you have such a vast experience of cardiac disease in India. You see such a huge variety probably than what we see here in UK. So I have much to learn from all of you.
Thank you. Those are kind words. We would be really delighted to have you as part of us. You'll get worried that why did I offer? Because you'll be bombarded.
No, I'm sure I will be. It is my privilege. But
Thank you.
I'm sure Bhavna will agree with that. And you, Raj, you yourself have been here, so you know what we see in UK and what you see in India. So
Absolutely.
Absolutely, Tarun. I think that was one of the reasons why I thought this talk is so important. Though nobody uses it, I think it's also good to know that there is nothing to feel bad because we are not missing out on anything.
No, absolutely. I think it's the reassurance and anything else.
Yes. And thank you so much. You've always been so humble, and I didn't expect anything less in this talk, Tarun, and really looking forward to seeing you so many more times, and definitely in October in IACI.
Well, thank you again very much. Again, my great pleasure and to be part of all of you.
Thank you, Tarun.
Thank you very much. Thank you.
Thank you. Take care. Good night. Bye-bye.
Good night. Yeah, good night.